Hello all, this is Dr. Priyadarshini, one of the mentors at StudyMedic, and today we are going to discuss on the topic Pediatric Gynecology with regards to our EFOG Part 1 exams. So, in pediatric gynecology, we can have questions pertaining to various syndromes that are in the pediatric age group, or the menstrual disturbances or disorders of sexual development, which are commonly asked. Starting on with a question, we can have few options of various syndromes like androgen insensitivity syndrome, Kalman syndrome, PCOS, Swyer syndrome, MRKH syndrome. So all these fancy names are seen in pediatric gynecology. So let us go through this lecture and understand how we come to conclusion of all these. I have some sample questions to start with. It says, for each of the following clinical descriptions, what is the most likely diagnosis from the option? So we have various clinical scenarios. For example, the first question says, we have a 16-year-old girl who presents with primary amenorrhea. She has normal secondary sexual development, and on clinical examination, she has a short blind ending vagina and her karyotype is 46XX. So we need to understand what is primary amenorrhea by definition, what can be the types of primary amenorrhea, the classification, and also how do we manage a case of primary amenorrhea if the various parameters like the secondary sexual characters, the clinical features, and the karyotype are provided. So before we proceed on to the questions, let us go into some discussion of this. So, what are the important topics we need to remember in this pediatric gynecology? One is about puberty and the disorders of puberty, the menstrual dysfunction, disorders of sexual development, some dermatological conditions, abuse. Abuse in pediatric age group is important, and also a little bit about pain and mass abdomen, which can present as an emergency. So, what do you mean by puberty? Puberty is the period of life that leads to adulthood. Now, there is a lot of physiological and psychological changes that takes place. What is considered as the appropriate age? It is between 8 to 12 and it usually spans over a period of 3 to 4 years. Clinically, the onset of puberty is marked by the presence of secondary sexual characters. So, what is the mark? We have telarchy, which usually is the first landmark, followed by pubarchy, and later on, the last one to set in is menarche. Now, this puberty is completely controlled by the hormones. We need the activation or the maturation of the hypothalamo-pituitary ovarian hormones. So from the hypothalamus, we have the gonadotropin releasing hormones, and from which it acts on the pituitary gland. From the anterior pituitary, we have release of LH and FSH. This LH and FSH will act on the respective gonads, and we have the testis in the males and the ovaries in the females, and the respective hormones are produced. That is testosterone in the males, which is going to play a vital role in pubertal development, and estrogen in the females. Now, we need to understand that the negative feedback is sent via the testis and the ovaries through these hormones back to the pituitary and hypothalamus so that we have a regulation of the hypothalamo-pituitary ovarian axis. So, to understand puberty better, we have the Tanner staging. We have a different description of the external genitalia appearance, the pubic hair description, and also the breast appearance. This will give us an overall idea of how the secondary sexual characters are being developed in both the sexes. Now, what do you mean by precocious puberty? Precocious puberty means the puberty the girl or the boy has attended before the expected age. So, the age limit has been considered as 7 years in girls, the white girls, 6 in the African American, and 9 years in boys. So, anything before this is considered as a precocious puberty. Now, this can be just an incomplete variant or it can be a complete precocious puberty. Now, what do we mean by incomplete variants? We just have one of the components that is present, which can either be a premature telarchy or an adrenarchy or a menarche. Now, understanding complete precocious puberty, there are two different types, which can be either gonadotropin independent or gonadotropin dependent. Independent ones are something that is happening in the peripheries, like an ovarian cyst or a tumor or an adrenal tumor, which can lead to this. One important syndrome to remember here is the McCune-Albright syndrome. So other endocrine disorders like thyroid or primary hypothyroidism can also present as precocious puberty. Understanding the gonadotropin dependent one, most of them are idiopathic. The other causes can be some central causes like a brain tumor, a hematoma or glioma of the hypothalamus, congenital anomalies like an hydrocephalus or arachnoid cyst, which causes some pressure effects, or there is some neurological insult which is caused because of some infection, trauma, or radiation. So, this is what we were discussing. We have two different types, central and peripheral. So whenever a question is being tested on precocious puberty, first we need to understand that we have to classify whether it is central or peripheral. And then depending on the features that is provided, we come to a conclusion. Now, the most common investigations that we do here are for a peripheral causes, we need to look at the peripheral changes like an abdominal or a pelvic CT or an MRI, and also what is the response to LHRH. Now, coming to the central causes, it is basically the brain MRI which is going to help us in the diagnosis to rule out central causes. However, remember, idiopathic is the most common cause of central precocious puberty. So the main difference between both are in central precocious puberty, there is a premature activation of the GnRH. Whereas in peripheral precocious puberty, we have excessive production of the end hormones, which is your androgen or estrogen. Now, in a nutshell, what do we do when we have a case of suspicious of a precocious puberty? First thing, we'll have to look at the secondary characters and see whether it is a isolated one or whether it is a central cause or a peripheral cause of a complete precocious puberty. So the first thing we do is a X-ray of the wrist and hand, and we look for bone age. If the bone age is more than one difference between the chronological age and the bone age, then we have to go on to measure the hormones. But if the bone age is normal, then we look whether it is a case of isolated causes of premature thalarchy or agenarchy, and then we only have to reassure the mother and reassess the child in 3 to 6 months. However, whenever we find an advanced bone age, we go on to measure the LH levels. If there is an increase in the basal LH, then we go and look at the GnRH dependent, that is the central precocious puberty cases. For central precocious puberty, the investigation of choice is going to be a cranial MRI. And if that is conclusive or if we find an evidence in that, then we assume that as to be the cause of this precocious puberty. However, if there is no cause found in a central on a cranial MRI, then we think of obesity being one of the causes, or whether it is some constitutional or idiopathic cause of central precocious puberty. Coming back to the LH levels. Now, what if the LH level is low or normal? Then we go and do the GnRH stimulation test. With the stimulation, if there is increase in the level of LH, again we think of central causes. Even with the stimulation, if the LH level is going to be normal or low, then we think of GnRH independent, which is a peripheral causes of precocious puberty. Again, rule out overweight and obesity. If that has been ruled out, then we go in for the individual evaluation of boys and girls. But if there is some factor of overweight or obesity that is present there, then we think whether it is without any gonadal maturity, whether it is just the signs of hyperinsulinism that the child is showing us. Now, there is no overweight and obesity, and we are thinking of peripheral causes. What do? We need to look at the sex of the child, whether it is a boy or girl. Again, we have to see whether it is an isosexual development or a heterosexual development. Now, what do you mean by isosexual development? A boy showing the androgenic features is called as an isosexual development. That is, the characteristics that the boy is displaying is appropriate for the gender. Whereas heterosexual means a boy is showing feminizing features like gynecomastia. Okay. Now, what are the causes for this? A boy exhibiting feminizing features, we'll have to rule out feminizing adrenocortical tumors or exogenous estrogen production. Whereas if the boy is going to show or present with isosexual characters, then we have to rule out conditions like Leydig cell tumors, beta HCG secreting tumors, or adrenocortical tumors, or exogenous androgen production. Now, in girls, again, we'll have to evaluate if it is an isosexual characters or heterosexual. So, in girls, by the term heterosexual, we mean there is some virilizing features like hirsutism. Again, most important cause, rule out congenital adrenal hyperplasia and adrenocortical tumors and virilizing ovarian tumors. For isosexual characters, we'll have to rule out ovarian tumors and McCune-Albright syndrome. So this is how, in a nutshell, we are going to deal with a case of precocious puberty. We need to follow the algorithm so that we are not missing on some important features. And we have to remember the GnRH stimulation test is a very important test to diagnose or differentiate the causes of central and peripheral precocious puberty. Now, what happens if the puberty gets delayed? Now, delayed puberty is usually defined when a boy is more than 14 years old, but the testis volume is less than 4 ml. Or a girl is more than 13 years old, but there is no breast bud formation. The first thing is to have a family history and a physical examination to rule out conditions like cryptorchidism. Next, you have to rule out all the systemic conditions like celiac disease and Crohn's disease, whether the child is on usage of steroids or radiotherapy or excessive physical activity, which can lead to this. And next comes the assessment. To start off, we start with the bone age. Now, we have seen the boy is more than 14, the testis volume is also less than 4 ml, and now we have assessed the bone age. Now, if the bone age is less than 13, then we consider it as a case of delayed puberty or hypogonadism. But if the bone age is more than 13, that is, the difference is only less than 1 year, then we think of hypo or hypergonadotrophic hypogonadism. Now, same thing applies for girls also. Since the cutoff is taken as 13 years, we see the bone age. If the bone age is less than 12, we assume it as delayed puberty or hypogonadism. But if the bone age is more than 12, then we think of cases of hypo or hypergonadotropic hypogonadism. The next is the evaluation of the hormones. We look at the basal level of LH, FSH, testosterone, or estradiol appropriately for the gender. Now, in selected cases, we can also do we have to rule out other conditions. So we can do tests like karyotype and MRI. Now, if all the levels of these hormones are low, then we think of central causes or hypogonadotropic hypogonadism. If the levels are high, then it is hypergonadotropic hypogonadism. So this is in a nutshell about evaluation of pubertal disorders, that is both precocious puberty and delayed puberty. Now, understanding the mechanism and the algorithm plays a vital role for us to solve all the exam related questions or understand the clinical scenarios that we face in the exams. Coming to menstrual dysfunction that the pediatric age group can face, menarche, the mean age across Europe is taken as 13 years. A range of 21 to 45 is usually considered normal in the adolescent age group. Now, in menstrual dysfunction, there are two important parameters to remember. One is about primary amenorrhea and the next one is about secondary amenorrhea. Now, coming to primary amenorrhea, what do we understand? That means the girl has not developed any secondary sexual characters with the age of 13 years, or there is secondary sexual characters but no menses and the age is 15 years. Coming to secondary menstrual dysfunction or secondary amenorrhea, there is no menses for a period of almost 3 months who has had a previous normal cycle. Or for 6 months of period, there is no menses who has had a previous abnormal or irregular cycles. Now, understanding primary amenorrhea is important. This is usually considered as one of the key factors or key topics to study for the exam. Now, first thing, we have to start with an history and a physical examination must be completed before we go in for any kind of investigations. We have to look whether there is presence of secondary sexual characters. If nothing is present, we go on with the hormones. We start with FSH and LH. Now, if the FSH and LH are low, then it is hypogonadotropic hypogonadism. If the FSH is less than 20 and LH is more than 40, we think of hypergonadotropic hypogonadism. So once we get the hormones and we see it is a case of hypergonadotropic, then we do the karyotyping. If the karyotyping is 46XX, then it is premature ovarian failure. But if it is 45XO, we think in terms of Turner syndrome. Now, coming to the secondary sexual characters. Once again, we are seeing that the girl has developed all the secondary sexual characters, but there is no periods. So, first thing we have to do an ultrasound of the pelvis to see whether uterus is present or absent. Now, if the uterus is absent or it is a small uterus or an abnormal uterus, we go on to do the karyotype. The karyotype, if it is 46XX, that means we know that genetically or genotypically also it's a female. So we come to the conclusion of Mullerian agenesis. The most common syndrome here is MRKH syndrome. Now, if in on the karyotypic analysis, we find that the karyotype is 46XY, then we think it is androgen insensitivity syndrome. Now, what do you understand by this? XY means it is a male. So phenotypically it is a female, but genotypically it's a male, and that's why we are not having periods. So we come to the conclusion of androgen insensitivity syndrome. Now, coming back, what if the uterus is present or it is normal? We'll have to think in terms of outflow obstruction. If there is any outflow obstruction, we think in terms of imperforate hymen or vaginal septum. But if there is no outflow obstruction, then we have to think in terms of secondary amenorrhea and rule out other causes of the same. So we have come across some various syndromes. Let's just look at the explanation of few of them. So MRKH syndrome is also called as the Mayer-Rokitansky-Kuster-Hauser syndrome, and this is characterized by congenital aplasia of the uterus. And the upper part of the vagina also is aplastic. So what happens? The woman or the girl is going to show a normal development of the secondary sexual characters, and the karyotype is also going to be normal. However, there can be primary amenorrhea because of the absence of uterus. So the main treatment option available for this syndrome is creation of neovagina. So for neovagina creation, we have two types of options of non-surgical treatment and surgical treatment. The non-surgical treatment include using methods like vaginal dilators, the Frank methods, the Ingram methods, etc. Or we can do a surgery and we can use some traction-based methods, either laparoscopically or open surgery, to create neovagina. Grafts like amniotic membrane can be used in creation of neovagina. Coming to androgen insensitivity syndrome, this again to understand the pathophysiology is very important. In androgen insensitivity syndrome, the individual can present with primary amenorrhea. The secondary sexual characters are going to be present. The basic pathology here is it is an X-linked recessive mutation of the AR gene, that is the androgen receptor gene. So the end organs are insensitive to the androgens. So, however, the androgen is being produced in the body. The karyotype is 46XY. So, genotypically, it is or the individual is going to be a male. But phenotypically, the characters are not present. So, how can we come to the conclusion? We have to do genetic testing and we have to look at the hormone levels. The hormone levels are going to show us increased level of testosterone and LH. So phenotypically, the individual is going to be a female, whereas genotypically, the individual is a male. So what are the treatment options we have for this? We have to do a gonadectomy to prevent malignancy. This is important because we have the gonads. The gonads can be an undescended testis which is present in the abdomen, which requires a removal. And we have to provide them with some options of hormonal therapy with the onset of puberty, depending on the gender identity. So gender identity is important in these individuals who present to us with primary amenorrhea. Now, again, this androgen insensitivity is also called as testicular feminization syndrome. This can be either complete or partial failure of the genitals to respond to the androgens. So, because and another thing to remember, it is an X-linked recessive disorder. So these individuals usually have a very well-developed testis, but an underdevelopment of other character features like epididymis, the vas deferens, the seminal vesicle, and the external genitalia like the scrotum and the penis. Now, because this testis is found in very much abnormal positions, most commonly in the inguinal region, and it is not present in the scrotum because scrotum as such is underdeveloped in them. Now, almost all forms of this androgen insensitivity syndrome are associated with infertility. This is another thing to be remembered. Now, based on phenotypic characters, this can either be a partial, a complete, or a mild variant of androgen insensitivity. Complete means the male fetus who has karyotype of XY is born with either a female characteristics of the external genitalia or an ambiguous genitalia. Treatment, gonadectomy and estrogen replacement therapy. Now, coming to mild varieties of androgen insensitivity syndrome, the external genitalia are that of a normal male. They can just present with some isolated infertility or very mild gynecomastia. The hair production, there can be a decreased secondary terminal hair and some amount of minor hypospadiasis can be seen. Now, since they have a very much normally appearing external male genitalia and the Wolffian duct structures are also appearing normal, most of them are not going to present to us with a primary amenorrhea. It's only based on the infertility evaluation when they have problems with conception, they present to the clinician. Now, for coming to partial androgen insensitivity syndrome, the external genitalia is partially masculinized but not completely seen. So, for them, the treatment option is going to be testosterone because the gender identity is already been made as a male. So, understanding the characteristics or the patterns of androgen insensitivity syndrome, the treatment options also do vary in all of them. So, going back to the questions, let's look at the scenarios. We have a 16-year-old girl who's presenting to us with primary amenorrhea. The secondary sexual characters are normally formed, and clinically also there is a short, blind, ending vagina. Karyotype is XX. Looking at these description, the most appropriate answer is going to be a MRKH syndrome. Next, we have a 15-year-old girl who's presenting with amenorrhea and abdominal pain. Clinically, there is a pelvic mass, and on vaginal inspection, there's a pink bulging membrane. So, this most likely is presenting to us with an obstruction. So, an imperforate hymen can be appropriate in this. Next, we have a 16-year-old girl who presents with amenorrhea and delayed puberty. Phenotypically, she is female and the uterus is also present. Her FSH level is elevated, but the karyotype is XY. So, in this case, if we see, there is a difference between the karyotype and the clinical presentation. So, phenotypically female, but genotypically male. So, we are dealing with a case of androgen insensitivity syndrome. Coming to the first one, as I told, it is a case of MRKH syndrome or Meyer-Rokitansky-Kusterhauser syndrome because there is absence of uterus. But the second one, we were thinking in terms of imperforate hymen, but the answer provided is a transverse vaginal septum. Let us see how to differentiate the both. In an imperforate hymen, the inspection of the vulva is going to give us a membrane that is blue in appearance. So there is transillumination of the darkened blood. Whereas a transverse vaginal septum will be considered whenever, because of the thick septum, we have a pinkish bulge. So remember, this is the key word to differentiate between an imperforate hymen and a transverse vaginal septum. It's blue in case of imperforate hymen and pink in cases of transverse vaginal septum. Coming to option number 3, we were thinking in terms of androgen insensitivity syndrome, but the answer is Swyer syndrome. So where is it? We have missed on this. Swyer syndrome is basically a form of gonadal dysgenesis when the karyotype is 46XY. There is 3 gonads, so there is no androgen production, and phenotypically it is the female. It is a female. The individual is a female, but there is no hormone feedback to the hypothalamus in the pituitary. That is the reason why FSH is elevated. Now, the three gonads do not make the Mullerian inhibitory factors, so the uterus is present. Whereas in androgen insensitivity syndrome, the uterus is absent. So that is the key word to remember. But the presence or absence of uterus is going to differentiate between Swyer syndrome and androgen insensitivity syndrome. I hope this explanation was clear to help us understand, to pick up the keywords which can help us in differentiating the various syndromes. So now we have another scenario. We have a 7-year-old girl who's brought to the clinic because she's been having regular monthly bleeds for the last 4 months. So first thing, we are dealing with a case of precocious puberty. We are suspecting that this is a case of gonadotropin dependent precocious puberty. So what is going to be the gold standard to diagnose or confirm the diagnosis? Now, having an accelerated growth velocity or an advanced bone age is only going to give us a suspicious of precocious puberty, but not a gold standard. A pearl-shaped uterine length more than 35 mm, again, no. A brain MRI to exclude intracranial pathology, however, that is not the gold standard. An LH peak, that is a luteinizing hormone peak after a gonadotropin releasing hormone stimulation, is the likely answer for this question. Now we need to understand that we are being tested on which is the gold standard or which is the key factor in diagnosis of this condition of precocious puberty, and it is an LH peak after a GnRH stimulation. So GnRH stimulation test is a very important test to diagnose the types of precocious puberty. We have another scenario here. We have a 5-year-old girl who is presenting to us with the history of accelerated growth, menarche, and signs of sexual development. So, again, it's a case of precocious puberty. On examination, we get light to dark brown spots, which are predominantly noticed on one side of the body without crossing the midline. So, here there is one peculiar feature that they have mentioned, that is this brown spots. So we know it is a case of precocious puberty, but however, what is the main diagnosis or the differential diagnosis? Is it a case of a central precocious puberty we are dealing with, or is it Cushing syndrome, or exogenous estrogen exposure, or iatrogenic excessive use of cortisol treatment, or McKeown-Albright syndrome? So here the buzzword or the key word to pick which helps us in the diagnosis is the dark brown spots, which are seen in a case of McKeown-Albright syndrome. Now, what is McKeown-Albright syndrome? It is a gonadotropin independent precocious pseudopuberty, which is caused because of the mutation in the GNAS1 gene. Now, the characteristics of this is presence of caffeolic pigmentation, which can be light brown to dark brown in color. Usually, there is a segmental distribution and doesn't cross the midline. Now, the associated features can be bony fibrous dysplasia, which is mostly affecting the long bones, the pelvis, the skull, and facial bones. It is a very rare syndrome, like 1 in 1 lakh to 1 in 10 lakhs. Another scenario, we have a 6-year-old girl who comes with a mother because she's been bleeding vaginally for the last week. Now, what is the most common cause of this complaint? Young girls just coming with bleeding, we have to see whether it is a foreign body or whether it's a case of precocious puberty, abuse, urethral prolapse, and vulvovaginitis. All the options that are discussed here can be a cause of bleeding. However, the most common cause of an idiopathic vaginal bleeding in young girl is because of vulvovaginitis. This is the most common cause in the prepubertal girls. Now, the reasons of this or the differential diagnosis can be because of a yeast, a bacteria, virus, or parasites. Lack of cleanliness, use of soaps and bubble baths can be associated with this. Sexual abuse is not very common in the development of vulvovaginitis. Low estrogen levels, thinning and dryness of the vulva can lead to irritation and itching in the prepubertal age groups. Because of the intense itching, there can be vaginal bleeding. So now we have another scenario. We have a 15-and-a-half-year-old girl who presents to the outpatient department complaining of absent menstruation. So it's a case of primary amenorrhea. On examination, she has well-developed breast, but there is no pubic or axillary hair. An ultrasound shows there is absence of ovaries, there is no uterus and no vagina. So we have primary amenorrhea, breast development, but no hair development. That means there is some problem with the androgens. Again, ultrasound is telling us there is no features of internal or external features of female genitalia. So what is our diagnosis? Can it be a case of, it is a case of androgen insensitivity syndrome, of course. Is it a case of complete, mild, or partial? Or are we dealing with congenital adrenal hyperplasia or true hermaphroditism? Now, looking at the options we have and looking at the clinical scenario, the most common one to fit in is going to be a case of complete androgen insensitivity. Remember, we were dealing of how to see the differences between complete, mild, and partial. So this particular scenario fits into complete androgen insensitivity syndrome. So this is in a gist to explain about the possible questions that we can expect under pediatric gynecology. However, remember there's a lot more to study, especially under the disorders of sexual development. Hope this video was useful in your exam preparation. But remember to stay tuned and subscribe to our YouTube channel to understand the various patterns of the exam, and also to go through the various module at the RRR series, which is going to come to your live, which you can see in the YouTube channel. And I have also provided you with the links to access all these videos. Wishing you all the very best for your exam preparation. Thank you.